everyone. Good morning to you all. Thank you for joining the thesis defense session today. The title of my thesis is Multimodal Guidance for Medical Image Classification. This work was done at the Medical Image Analysis Lab of Simon Fraser University and was funded by MITAX, NSERC, and the BC Cancer Foundation. This thesis is based on the work that was recently accepted to the MICAI conference titled Deep Multimodal Guidance for Medical Image Classification. And this would be presented as a poster next month during the conference. So before I get into the details of this work, I'll break down the title of this work. We start with medical image classification. So given the image of a patient's diseased organ, the goal is to identify the disease present in the image. So for example, in the case of this brain MRI, the goal is to diagnose the disease label that could be glioblastoma, oligodendroglioma, or astrocytoma, or in this case of skin lesion, it could be the basal cell carcinoma, nevus, and so on. So to do this, we use deep learning, where we train end-to-end networks to map from the image space to the label space. And the next term in our title is multimodal, which I think is an important aspect of medical image analysis, where the clinician looks at multiple modalities of data before proceeding to the diagnosis. So we have multimodal data of brain tumors, and similarly, we have the multimodal data of skin lesions. The final term in the title is guidance, which is specific to our contribution, and I'll be explaining this in the subsequent slides. So the rest of this presentation is organized as follows. We start with the motivation, related works, and proceed to the methodology. And further, we have the experimental setup, results, and finally the conclusion and future work, similar to how it was organized in the thesis. So we start with the motivation. What is guidance and why is it needed? So in medical image analysis, there is a trade-off between the acquisition of a particular modality and the information it delivers. So in simple terms, what this means is the modalities that are acquired easily, in most cases, are the ones that provide less information regarding the disease. So for example, if we take the case of brain tumors, on the left, we have the brain MRIs that are acquired through non-invasive procedures that take around 30 minutes for acquisition, whereas on the right side we see the invasive biopsy-based tissue images that require surgery followed by the processing that includes the sectioning of the tissues and staining and further the digitization, which overall is a tedious process. When it comes to the information, the histopathology is the golden standard for clinical diagnosis. Similarly, in the case of skin lesions, we have the clinical images that are acquired through consumer-grade cameras that are ubiquitous, whereas the image on the right shows a dermatoscope which acquires a high-resolution image, and this requires a trained clinician to acquire such images. And as mentioned before, the modality that involves the expensive acquisition is the one that provides the concrete information regarding the underlying disease. So to summarize, we have two modalities, the inferior and the superior. And with guidance, what we try to do is we want to leverage this existing multimodal data in order to improve the performance of the inferior modality, so as to have a better result with the easy acquisition. So in deep learning terms, what this means is during training, we make use of the multimodal information from the inferior and superior modality, whereas during the inference, we use the trained models to improve the performance with only the inferior modality inputs. So moving on to the related works. So we start with multimodal learning. So broadly, this multimodal learning can be broken into three frameworks: joint representation, coordinated representation, and translation framework. So joint representation framework is the most popular, as it involves the fusion of multiple latent representations from the different modalities. And this fusion could be a simple concatenation, pooling, or so on. And this could be done at the input phase, the feature phase, or the decision phase. The feature of this framework is that it requires the presence of all modalities during the inference phase. So the second framework is the coordinated representation framework, which involves some sort of a constraint between the latent representations of different modalities. So the constraints could be a similarity-based constraint, orthogonality-based constraint, etc. And the application of this framework has been commonly seen in the intersection of vision and language. The feature of this framework is that it doesn't necessarily require the presence of all modalities during the inference. There is a subfield of coordinated representation learning framework called multimodal co-learning, which specifically tries to help the resource-poor modality during with the help of the resource-rich modality. The third framework is the translation framework, which, as the name suggests, involves the translation from the source modality to the target modality. However, this framework is not suited to our problem due to a few reasons that I've listed below. That is the dimensionality difference, which is common in medical imaging, and the size difference, for example, between the size of the histopathology image and the MRI, and the small size data sets that are again common in medical image analysis that prevent the that hinder the translation performance. The second field that we relate our work to is the student-teacher learning, also known as knowledge distillation, which aims to transfer the knowledge from the teacher network to the student network. And this field is commonly used in model compression, where a bulky teacher is used to train a lightweight student, and in knowledge transfer, where the teacher network has access to more label data, whereas the student has less annotated data. A subfield of ST learning is cross-modal ST learning, where the teacher network is the superior modality, and the teacher network is the superior modality, and the student network is the inferior modality. And the goal, as we mentioned before, is to take advantage of this teacher network to improve the performance of the student network. So to summarize, we have two fields, that is multimodal learning on the left and student-teacher learning on the right. And at the intersection, we have multimodal co-learning from the multimodal learning perspective. And from the ST learning perspective, we have the cross-modal ST learning, which is where our work places. So moving to the methodology section, this is the overall architecture diagram of our proposed method, and I'll be explaining every block. We start with the modality specific classifiers of both the modalities, the inferior and the superior, and we train both these networks using cross entropy laws. So as you can see, the E represents the encoder that extracts the feature latent representations, which are fed to the decoder that are the fully connected layers that map to the labels. So once we have both these networks trained, we move to the second step, which is the training of the guidance model. So guidance model represented with G is autoencoder-like model that maps from the latent representation of the inferior modality to that of the superior. And we make use of a mean square error loss to help the reconstruction. So moving to the third step, which is the proposed guided model. This involves the use of the pre-trained networks from the previously trained models. As you can see, the lock denotes the frozen layers. So we start with the inferior modality image, which are being fed to the encoder, and the generated latent representations are fed to the guidance model. And the pseudo superior features that we get out of the guidance model are fed to the pre-trained superior decoder to get the classification. The drawback of this, however, is that the final predictions are made based only on the pseudo superior features without taking the direct advantage of the inferior modality latent representation. So to circumvent this, we have the fourth model represented by g of I plus I, showing the latent representations that are used in the classification. So here we concatenate the latent representations that that of the pseudo superior along with the original inferior modality latent representations, and we train a final common decoder on top of this for the final classification. So the fourth part is the experimental setup. So we have two data sets. The first one is the rat path. This involves the radiology from the rat and the pathology of the path. The radiology involves multi-sequence MRI, which are three-dimensional, and the image dimensions are mentioned here. So the radiology involves four different sequences: T1, T2, T1 weighted, and the T2 flare. And the histopathology, on the other hand, involves the high resolution whole slide images with sizes as high as 100,000 by 100,000. And as we mentioned before, the radiology forms the inferior modality and the pathology forms the superior modality. And the second data set that we work on is the DERM 7-point data set, which again has two modalities: clinical on the left and the dermoscopic on the right. And as you can see, the dermoscopic, showing the subcellular features, forms the superior modality, and the clinical the inferior. So this data set involves 8 different classification tasks, 7 from the 7-point criteria and 1 from the diagnosis. And melanoma inference is another subtask that could be done in both sections. First, through the 7-point criteria, and second, through the direct diagnosis. When it comes to our experiments, we compare 5 different models. The first one is the superior modality model. Next is the inferior modality model. Then we have the multimodal model that concatenates the latent representations of both the modalities, and even during inference requires the presence of both the modalities. Then we have the guided model uh, represented by G of I. And finally, we have the guided model that involves the concatenation of the two latent representations. So moving to the results section, uh, we have the results on the RADPAT datasets, where R denotes the radiology and P the pathology. And if we examine closely, we observe that the multimodal model denoted by P plus R performs the best among the 5 models, followed by the superior modality model uh, denoted by P, and then we have the inferior modality model. And comparing our proposed method, which is denoted in the last row here, and this outperforms the original inferior modality model, which is the main contribution of our work. While the input is only radiology, our proposed model leverages the existing multimodal dataset and improves the performance. Delta R here denotes the improvement in performance of the proposed method over the original inferior modality model. Similarly, in case of DERM 7-point dataset, we have clinical, which is the inferior, and dermoscopic, which is the superior. And again, we observe the similar results. That is, the multimodal model performing the best among the bunch, followed by dermoscopic, which is the superior, and then the inferior, which is C, the clinical. And comparing to our proposed method, we see that the proposed method that concatenates the two latent representations outperforms the original inferior modality model. And delta C here again is the improvement in performance of the proposed over the baseline. So the melanoma inference, as I mentioned before, could be done either through the direct diagnosis or through the 7-point criteria. And here we can see that through the direct diagnosis, we see the guided clinical, which is the final proposed model, outperforms the original clinical model, and the AU-ROC scores are mentioned in the parentheses. Similarly, in the melanoma inference through the 7-point criteria, we observe that the AU-ROC of the proposed model is more than that of the baseline inferior modality model. So this plot shows the improvement across multiple tasks in our RADPath dataset. So we see that the proposed guided model outperforms the baseline inferior modality model by a certain amount that is denoted in the plots. And similarly, in case of the term 7-point dataset, we observe that the improvements are mostly positive, while it's negative in one case. To summarize the results, we start with the superior modality model. And as you can see from the plot, the superior modality, denoted in green, outperforms the inferior modality. So in a clinical setting, this is an expected behavior. And what we observe is that even in a deep learning setting, the superior modality outperforms the inferior. The multimodal model, denoted by S plus I in red, outperforms the superior modality. This shows that in a deep learning setting, the inferior modality does add something to the classification performance over the superior alone. But we observe this behavior not in 100% of the cases, as there are some negative cases in the DERM 7-point dataset. Then we have the proposed guided model, denoted in I, in the, denoted G of I in yellow, that performs the worst among the 5 models. However, our proposed model that concatenates the latent representations outperforms the original inferior modality model, which is the main contribution of our work. And finally, in case of the RADPath dataset, we have our proposed model that is comparable to that of the original multimodal model. So what this means is that in case of RADPath datasets, we are able to make up for the lack of the superior modality during the inference. And we observe this in case of the all-sequence MRI guided model, which is the MRI model with all the MRIs involved. So finally, the last section, that is the conclusion and the future work. We start off with a clinically motivated task where we have a trade-off between the acquisition and the information delivered by a particular modality. We leverage the existing multimodal data in order to improve the performance of the inferior modality during the inference. And to do this, we use multimodal and student-teacher learning techniques. The result is that with the help of the prior works, we are able to improve on the performance of the inferior modality without having access to the superior modality during the inference. And our promising results in case of the RADPath dataset show that the future works could aim at mitigating the expensive acquisition of the superior modality. Moving on to the future works. So there are multiple directions in which the current method could be extended, and some of them are the end-to-end training. So our proposed method, our current method, involves a multi-step training process, whereas end-to-end training, uh, end-to-end training procedure, which in a single back propagation could train multiple models, would probably be better than the proposed method. Secondly, the modality-wise attention. So while our proposed method ignores the information content that is provided by the individual modalities, an attention-based scheme could be useful in uh, prioritizing the modalities. The third architectural improvement is the aggregation strategy. We follow a simple concatenation-based strategy, which could be improved by techniques like the Kronecker product that is shown in the figure here. And the next one is the augmentation invariant guidance. In the current method, we our guidance model G maps from the original latent representations of the inferior modality to that of the superior. And when I say original, what I mean is that the the images are the images are not augmented. So an augmentation invariant guidance would allow for data augmentation, which could improve the performance of the overall guidance and further the guided models. And, and finally, we have the domain generalization, uh, which I think would improve the scope of our work, as the current method relies on uh, the inferior modality inputs to be from the same hospital as that of the multimodal data that we trained on, whereas a broader application could be multimodal data from hospital A being used to improve slash guide the performance of the inferior modality from hospital B. So that concludes my presentation. Thank you. And before I hand over the microphone to the committee, I'd like to take a moment to thank the people who were integral in getting me here. So firstly, I'd like to thank my supervisor, Professor Gassan, for everything, starting from giving me the opportunity to work at his lab to helping me publish my first paper. So thank you very much. Secondly, I'd like to thank the members of the committee, Professor Manolis, Professor Yagis, and Professor Ali for their valuable time and feedback on the thesis. And finally, I'd like to thank my favorite people in Canada, the members of the Medical Image Analysis Lab, and also some people who are in the audience members today. It was wonderful sharing the lab with you and getting to learn from you. Special shout out to Kumar Abhishek, Ben Cardone, and Beena Jen for motivating me and helping me throughout my master's program. Thank you all.